So today my talk is going to be on my essay, Rethinking Pain, the Gut Microbiome as a Novel Target in Inflammatory Arthritis. So I would like to start off with an important quote from The Lancet that says, "To live with chronic pain is to live with daily challenges around simple tasks that others take for granted." Now, I think this is a really important quote because it highlights quite an often underexplored aspect that chronic pain not only continues to persist beyond sort of the normal healing stages, but it also has profound effects on the patient's mental well-being, their social life, and their overall personal life. So, why did I choose to write my essay on inflammatory arthritis and the gut? Well, it actually stems from a personal reason. So when I was around 14, I suffered from severe pain at the base of my spine, and this eventually spread to my hip, my knee, my shoulder, my neck, and sort of all around my body. And this lasted for around 3 years. So it made sort of simple activities such as sitting down to study for my GCSEs quite difficult, meeting up with friends, and playing sports like rugby or football all really quite challenging. And so, despite having a few corticosteroid injections and taking anti-inflammatory drugs, the pain still wasn't resolving. So, unfortunately, this doesn't just apply to me. And despite some sort of remarkable progress made in rheumatology research, many inflammatory arthritis patients still remain in pain. So, approximately one third, so we have some stats here, I'm just going to read out. So, approximately one third of ankylosing spondylitis patients have symptoms despite being on optimal standard therapy. And we've also know that TNF inhibitors have been shown to have an inadequate response in about 40% of patients. And so we know these consequences extend beyond just the joint inflammation. So in terms of mental health, we know that ankylosing spondylitis patients have roughly 1.5 times greater risk of depression and anxiety. And this can, it can heighten pain perception and it can sort of make it harder to cope with the pain. And then we also know that a recent UK study found that it costs around £19,000 per patient per year, um, for these patients. And most of this money is not from the NHS spending, but it's actually driven by sort of missed work and early retirement from the economy. So during this challenging time, when the corticosteroid injections weren't working for me, I experimented with various different alternative treatments. So I tried out like acupuncture, different holistic practices, and so some of them did work, and some of them definitely didn't work. But I think one of the key changes that I made was changing to an anti-inflammatory diet that had like a strong evidence base behind it, and I also implemented some targeted supplements that still have promising evidence, but it's not quite enough evidence to bring it to clinical practice just yet. And I think it was a combination of these lifestyle changes that I made, in addition and coupled with the treatment that I got from the hospital, that eventually led to the resolution of my symptoms. And I'm now happy to say that I'm able to play sport and sit down without any pain. So that's, I'm very happy about that. But this whole experience really fueled my curiosity to explore more about the gut microbiome as a potential target for chronic pain. So one of the first studies I read was this meta-analysis from 2024. And if you haven't seen one of these before, it's called a forest plot. And this little diamond here at the bottom indicates sort of the overall pooled effects across these various different studies. And so in this specific meta-analysis, it showed that there was a lower gut microbial diversity in chronic pain patients. So it's showing a consistent association between imbalance in gut bacteria and chronic pain patients. So I then went on to explore a little bit more about this and see what the gut-brain axis was. And so I came across the concept of a gut-brain axis, where an imbalance in gut bacteria can communicate with the brain through, we have here immune, endocrine, and sort of metabolic pathways where the brain and the gut can communicate with each other. And so essentially there are three ways that an imbalance of gut bacteria have been proposed to contribute to pain. So number one, we have the concept of a leaky gut. And this is where we know that chronic pain patients can experience quite a lot of stress, and this can increase the intestinal permeability. And this can cause certain things called endotoxins. So LPS, as an example, can enter the blood and activate glial cells, and this can lead to inflammation and amplifying the pain signaling. Number two, we have microbial metabolites. So we know that dysbiosis of the gut can increase certain metabolites such as TNF alpha and IL-17, and this can sensitize the pain receptors where you might feel more pain to less sort of stimuli and less stimuli would be the word. And then in contrast, we know that a healthy microbiome is able to produce short chain fatty acids such as butyrate, which have been shown to exert an anti-inflammatory effects. And then finally, we have neurotransmitter modulation. So reduction of certain bacteria can reduce certain neurotransmitters, which again leads to reduced pain control. So ultimately, the key takeaway from this slide is saying that the disruption of the gut microbiota can sometimes amplify the persistence and the perception, I would say, of pain. And so this is another useful diagram illustrating that ankylosing spondylitis and inflammatory bowel disease may have a common cause, with the dysbiosis leading to inflammation. So we know that clinically there is a strong correlation between the severity of gut inflammation and the degree of spine inflammation in ankylosing spondylitis. So essentially, this is supporting the idea that both of these conditions may be downstream consequences of the same microbiome cause. So given these links we've talked about, targeting the gut microbiome through interventions could offer potentially a promising avenue. So we're going to explore 3 evidence-based approaches today, and that includes personalized gut profiling, an evidence-based anti-inflammatory diet, and targeted supplementation. Before we get into these, it is quite important to note that many of these are still experimental, and they should definitely not be a replacement for standard therapy, but they're more offering optimism to potentially complement the therapy within the future. So the first intervention, we have personalized gut profiling. So recently, with the development of artificial intelligence and certain technologies, there's certain things called shotgun metagenomics, and you can use some of these tests to map thousands of microbes within your gut. And some people have proposed that these can potentially identify dysbiosis patterns within your gut bacteria linked to inflammation and pain. So this could potentially open the door to tailored adjunct therapy. And there have been some early proof of concept studies, but I'd say the evidence base is still emerging. So we know that one study from the Mayo Clinic have developed a machine learning model that could forecast the improvement of patients to treatment with a 90% accuracy based on their baseline gut microbiome profiles. It is also important to note that this was just an internal validation set, and so we need larger multi-center trials with external validation to fully validate this personalized gut profiling. And I think overall this offers sort of a glimpse to personalized medicine that's going to become more common in the years to come. So now diet is probably one of the most practical ways we can influence the gut microbiome. So one of the strongest evidence bases is around the Mediterranean diet. So we know that the Mediterranean diet has shown improvements in pain and physical function. And we also know a recent systematic review has shown it's been able to show a modest drop in DAS28, which is the criteria for inflammatory arthritis. And so the mechanism behind this is likely through more fiber, which has allowed more short-chain fatty acids to be produced within our gut microbiome, and such as butyrate, and certain foods may have certain compounds which can help to shape healthier taxa. So we know that olive oil has certain polyphenols which can act as antimicrobial and potentially shape healthier taxa within your gut microbiome. So additionally, there are also 2 other low-risk add-ons. So we have omega-3 fish oil. These have been shown to enrich anti-inflammatory gut bacteria, and they've also been recently shown to potentially reduce reliance on anti-inflammatory medications. And then finally, we have curcumin or turmeric, and a recent meta-analysis showed that the pain it reduces pain and inflammation with a similar efficacy to non-steroid anti-inflammatory drugs with fewer side effects. However, I should note that with this specific study, there is a slight risk of bias, as some of the randomized control trials were funded by manufacturers of turmeric, so I would be careful about interpreting this. Now onto beyond diet, there are also a couple of targeted adjuncts that can potentially act on the microbiome. So I'd say lactoferrin is quite an interesting compound. There's been some early evidence to show it can reduce endotoxin leak by strengthening the gut barrier integrity, and it's also been shown to potentially shift immune signaling from Th17 towards T regulatory cells, and showing less joint inflammation and damage. And so we also have another supplement called N-acetylcysteine, which is also known as NAC. And this is a glutathione precursor, which has been shown to lower oxidative stress and potentially disrupt bacterial biofilms. But again, the evidence base is still early on, and there needs to be more studies to explore these as potential adjuncts. I would say the key takeaway message from this slide in general is that I think personalization is key. So rather than having a generic probiotic blend, I think future strategies in the years to come is that we may be able to target specific microbial deficits using the previous stool tests and GI mapping. But this is still an experimental approach, so we still need some more evidence to fully validate these proposals. So finally, lifestyle also matters because not only does exercising, eating healthily, and managing your stress enhance quality of life, but it can also modify the microbiome. So we know that exercise is quite strong evidence, particularly in axial spondyloarthritis. So meta-analyses have shown that it can reduce pain and disease activity, but also less well known, it can help the microbiome. So it can increase the microbial richness, and it can increase short chain fatty acids such as butyrate, which may be able to strengthen the gut barrier. Now we can look at stress, and so we know that stress can be a pain amplifier. So even one night of sleep loss can trigger hyperalgesia. So this is something that I definitely experienced in my time as a chronic pain patient. That particularly when I wouldn't have much sleep, the next day my pain would be a lot worse. And then simple things as even someone sort of touching my back would really send like a spasm through my back, and it would be quite excruciating pain. So we know that trying to maintain our sleep hygiene can reduce. So as we can see in here, it can reduce beneficial commensals, and it can potentially decrease the gut permeability, so we can reduce our inflammatory cytokines. So essentially, improving sleep can stabilize the gut-brain signaling. And then finally, when we look at stress, we know that stress can activate the HPA axis, and this can potentially increase the gut permeability and amplify central pain pathways. So just to be balanced, there are some limitations with this proposal. So firstly, there is a large evidence gap. So we know that most of the human microbiome data in arthritis and chronic pain is associative and not clearly causal. So we know that many of these animal or germ-free models don't capture the full picture, and there can be some confounding effects and also some psychosocial factors that aren't quite incorporated. Number two, with the methodology, we only have a few large interventional randomized control trials, and there's an urgent need for more. And I believe that with these trials, we should have standardized metrics to allow comparisons between the studies, so we can come to justified conclusions. And then thirdly, equity and clinical utility. Microbiome profiling is still emerging, and it's quite a new concept. So at the moment, it's very expensive. So it does risk widening disparities. But if we can validate it does work, it can potentially save scarce resources in the NHS and potentially reduce ineffective care. So just to close in inflammatory arthritis, pain can persist even when uh, inflammation is treated with biologics. And we believe that targeting the microbiome is best viewed as a set of adjuncts rather than complete replacements. So the model I'm proposing for is a therapeutic triad. So number one, we're talking about the treat target model. So we're talking about continuing the model we have at the moment to suppress inflammation. Number two, we're talking about adding personalized microbiome modulation. This is Mediterranean style eating, eating lots of fiber so we can produce those short chain fatty acids. And then additionally, potentially adding in some targeted specific supplements. But I believe this will become more common in the years to come when more evidence emerges on this topic. And number three, integrative lifestyle support. So exercise, sleep, stress management to strengthen that gut-brain axis. And what's next and what's the next research priority to continue on this topic? So firstly, we need some more large human randomized control trials to use outcomes that matter to patients. So this can include quality of life and pain interference. And we can say this, there are some immediate opportunities lying in. So good afternoon, everyone. My name's Finton. I'm a third year medical student from the University of Edinburgh, and I'm currently intercalating at Imperial College London in head-to-head diet trials with microbiome and pain outcomes. Great, thank you for listening, and I'm happy to take any questions.